it's by no means in-depth look at neonatal jaundice. I mean, that's more for the pediatric uh, department. But for us, we still need to know as emergency medicine clinicians, what is jaundice? How does it present? What's our differential? Um, and in terms of treatment, that's also a whole teaching session on its own. So I didn't really go into that much detail. So bilirubin is formed by the breakdown of hemoglobin. Unconjugated bilirubin is bound to albumin that gets transported to the liver, then it's conjugated by glucuronol transferase and excreted into the bile. So there's three factors that contribute to neonatal jaundice. So it's either you are producing more bilirubin, or whatever is produced is not cleared or excreted, or there's some reason for increased intrahepatic resorption. So you can look at neonatal jaundice as unconjugated or conjugated, and conjugated is always pathological in the neonate. So, I mean, if you just Google neonatal jaundice, there's several different classifications. I like this one, unconjugated versus conjugated, and then if you go down, unconjugated, physiological, and pathological, and then conjugated, like I said, it's always pathological, and you just need to know if it's outside of the liver or inside the liver. We will discuss most of this, but this is just a different classification where they break it down. Is it hemolytic or non-hemolytic? Or if it's hemolytic, is it intrinsic or extrinsic? So first up, in terms of unconjugated hyperbilirubinemia, which is physiological jaundice, usually resolves on its own. In a term baby can last about 2 weeks, and a premature baby can last 3 weeks. This is purely just because it's an increased amount in red cells. Your red cell lifespan is decreased, and there's just a delayed metabolism of bilirubin. Okay, so that's physiological jaundice. In terms of breast milk jaundice, begins usually at day 3 to 5, and it's often can last for longer than 10 days. This is children that's well, they're feeding well, and if you look at the literature, there's a few theories, but the one that seems to be most prudent is that in breast milk jaundice, there's a high concentration of beta-glucuronidase, and this leads to increased bilirubin reabsorption, which then obviously leads to jaundice. Okay, this in comparison to breastfeeding jaundice is where there's a decrease in breast milk intake, and because you're not feeding that well and trying to establish breastfeeding, your bowel motility and bowel motion is altered, and this means that less bilirubin is removed, and this causes jaundice. And the way we treat it is to first you make sure that the whole latching, all those things are adequate, and then you counsel the mom that she should breastfeed, not on demand, but like every 1 to 2 hours. So they recommend about 10 to 12 times in a 24-hour period. Okay. Obviously, for us in the emergency department, make sure that all those big scary things are sorted before you just label it as this. Okay, in terms of unconjugated pathological jaundice, hemolytic. So if you look at the hemolytic causes, the big ones, ABO incompatibility, your baby will come out jaundice. And then sometimes you can see this in the ED, especially now where we have the whole movement of anti-vaxxers, where they don't want vitamin K to be administered at birth. We actually get this day 1, day 2 neonate with intraventricular hemorrhage and subsequently jaundice. Also, just to remember, I mean, we have quite a bit of foreigners in our country, so sickle cell anemia, thalassemia, those type of things should be on your differential if you suspect unconjugated pathological jaundice. The non-hemolytic causes, is obstructive, metabolic, infectious. Always think of your torch infections, sepsis, and then obstructive. A little bit later, something like Hirschsprung's disease, or pyloric stenosis at your 6-week-old male babies. And then your metabolic causes, hyperthyroidism, Gilbert syndrome. We don't really see these things, but I mean, it's good to have a good working diagnosis and differential for whenever you see patients. In terms of conjugated hyperbilirubinemia, like I said, it's always pathological. Again, sepsis, torch infections. For those of us that's been through ICU, and for those that are going, just remember certain drugs, and then obviously TPN is a big cause for this. As part of your history, always make sure to ask your patients, how does the stool look? How's the urine? You don't want to miss biliary atresia because it's actually a reversible disease if you catch it early, and they can fix it with a Kasai procedure. But that's where my knowledge about that stops. So I can't tell you anything more about the surgery. But yeah, that's just a brief overview of jaundice and what you need to be thinking of.